Good evening, and thank you for attending AACP's webinar with Dr. Angela Tenholder presenting Looking Beyond the Airway and into the Future of the American Board of Craniofacial Dental Sleep Medicine. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 50 minutes and is followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box located at the bottom of your Zoom screen, and we will address them at the end of the presentation. Dr. Tenholder has a professional affiliation with the Synergy Academy, LLC, and the AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 business days. I would like to mention some upcoming events for the AACP. Registration is open for 2 AACP mini courses. Oral Appliance Therapy, a comprehensive approach to TMD and sleep medicine on July 18th and 19th in Raleigh, North Carolina. The curriculum covers foundational knowledge of oral appliances and progresses into advanced topics like neuromodulation, phased treatment planning, and the use of appliances in managing conditions such as sleep apnea, bruxism, and TMD. You can also register for AACP's Advanced Injections course on September 26th and 27th in South Bend, Indiana. This program will be a hybrid of pre-course virtual review and hands-on techniques for injections, drawing blood, and osteopathic manipulative treatment. Also, we hope you plan to join us for AACP's Airway Anatomy Forum in Santa Clara, California on October 24th and 25th. This event will bring together airway experts from dentistry and medicine to discuss the critical connections between midface anatomy, functional breathing, and brain health. We are excited to have Dr. Angela Tenholder present this evening. Dr. Tenholder is currently serving as the president of the American Board of Craniofacial Dental Sleep Medicine. Together with the ABCDSM Board of Directors, they have created new and innovative opportunities for members of our professional communities to learn about the emerging research and exciting opportunities in dental sleep medicine. These include an emphasis on the role of pediatric airway in neurological function as a reflection of the critically important neurodevelopmental process. Dr. Tenholder is passionate about sharing concepts of neurodevelopmental dentistry and its effects on the lifespan. With that, I will hand it over to Dr. Tenholder.
Hi, welcome to the webinar tonight. So the title of my presentation is Looking Beyond the Airway and into the Future of the American Board of Craniofacial Dental Sleep Medicine. Without change, there is no innovation, creativity, or incentive for improvement. Those who initiate change will have a better opportunity to manage the change that is inevitable. William Pollard. So as we introduce our concepts today, as the emerging science highlights the importance of the neural circuits and their role of controlling every aspect of sleep and wakefulness, the role of dentistry is being elevated as a primary care provider of the airway, as well as sleep physiology throughout the lifespan. And evidence-based providers are encouraged to look beyond the structural aspects of the airway anatomy and explore the opportunities created by optimizing neurological function. And dentistry holds a unique and powerful role in assessing not only symptom management, but also the underlying causes of poor sleep quality and sleep apnea. The word neuromodulation and neuroplasticity as well basically boils down to the phrase changing minds and our ability to change our mind. And to do that, sometimes we have to challenge some paradigms. So the learning objectives today are to understand anatomy and physiology as well as the anatomy. We're all really good at understanding anatomy for the most part in dentistry, but physiology was a little while ago in dental school. So optimizing the trigeminal region and the neural circuits as well as their expression on sleep apnea is going to be one of our major topics today. We're going to explore the opportunities for efficient and effective modulation of the trigeminal neural circuits through the application of both dental appliances and complementary therapies designed to support an improved functional capacity for patients of all ages. And we also want to learn some of the exciting changes that are happening in the ABCDSM as the organization evolves to meet the needs of our professional community. So I'll introduce myself, tell you a little bit about where I am so you know where I came from and where I'm going. As Shaylin said, I'm the current president of the American Board of Craniofacial Dental Sleep Medicine, where I'm board certified. I'm currently on the board of directors for the Academy of Craniofacial Pain, where I hold a fellowship, and I have a fellowship in the Academy of General Dentistry. And all those letters are really great to have, but my most important initials are Mom and Mrs. because my family and my husband needed me to help with some of the issues they were having, and that went beyond drilling and filling and into understanding how to help their mouths help their body and their brain. As a result of being put in a position to ask the question, what would I do if this were my child, when babies were brought into my office after being an oral A's provider that needed help, I developed Baby Lays as an application of neuromodulation using 1064 nanometer wavelength for the 0 to 2 population. And that changed my life. And now that I'm a grandma, as of last Friday, it's even more impactful. And yes, I've already had one session going on one more tomorrow night for this little girl. I'm an instructor for ALF therapy, oral A's and restore Lays, which is a combination of dual wavelengths and appliances. I like to call myself a diversified dentist. I like to do all things, including problem solving. I'm kind of like the MacGyver of dentistry. I look at it like that. I've had a lot of training in cranial osteopathy, as well as physical therapy and chiropractic, sports dentistry as a soccer mom, biological dentistry, and this all came because I was a former chronic pain patient myself, and my husband was diagnosed with sleep apnea while he was in the Air Force. I'm a perpetual student because one thing that I know is that I don't know everything, and that I want to continue to learn from those who also want to continue to learn. And as a result of being the blessed position that I've been in, I've been able to speak and educate to organizations and providers from all over the world. And for that, I'm very, very grateful. My disclosures are: I'm the president of the Alpha Interface Academy, the Synergy Dental Solutions, which is my dental office, and the Synergy Academy. Innovation is such an important thing in any industry, and the ABCDSM is dedicated to supporting the provider who strives to have access to as much knowledge and as many tools as possible to better serve their patients. And as I mentioned previously, the role of dentistry is being elevated as a primary care provider of the Airway. When I chose to go to dental school, it was primarily because I didn't want the responsibility of medicine. I didn't want to have to tell a mother that their 2-year-old was going to die of leukemia, or that what I did that day was going to have a huge impact on the quality of someone's life. I just didn't want the responsibility. But whether we know it or not, we are in the hot seat of being the primary care provider of the Airway, but also our ability to literally change the brain to neuromodulate through the trigeminal neural circuits. I'd like you to consider the opportunities that are provided through the access to care that we have for our patients as well. And if we have an educated treatment team that can communicate those opportunities to our patients and our communities, we can better serve them. Our goal would be to balance form and function and have an acute awareness of the trigeminal neural circuits. And as we learn more about why some therapies succeed while others fail, it's our job to learn from our lessons. That's why dentistry and medicine and chiropractic are called practices. We learn, and that's what evidence-based medicine actually is. Not following the leader, but following our experience. And an elevated understanding of the emerging science is what I would like to bring to you this evening. Embracing the new information that's out there might include letting go of what we thought we knew about sleep medicine as a purely structural based approach. The current opportunities and obstacles for the dental and or the orthodontic provider include oral appliance therapies, because that's our workhorse. That's where we are most of the time. We're looking at, a mandibular advancement appliance, different designs, different reasons, different applications for them. But they can actually be friends with benefits if you understand how to modulate them to support not only the structural aspects of the airway with moving the mandible forward and changing oral pharyngeal volume, but also meeting the requirements of a functional neural circuit. And then we have our surgeries and their surgical interventions, which we all know can be highly successful. And we all know sometimes don't give us the results that we're looking for. But what if we could screen our patients and go into it wondering if they do have a neurological primary reason why they're not breathing well, or their airway didn't develop, or their swallow didn't develop? What if we could have a screening tool to figure that out? We can. Then we have our laser-assisted uvulopalatoplasty, which throughout the years has been, we've had our seasons of the radio frequency ablation. We've done all the things. But the questions that we need to ask ourselves with that, with all the different wavelengths and all the different techniques, and are we looking to just modify the tissue volume, or do we actually want to restore function to that tissue as well as reduce the palatal flutter? And then the miracle meds and peptides that are coming out are super exciting to appreciate the metabolic and neurotransmitter-based aspects of sleep physiology that are becoming more and more in the forefront as more patients are taking GLP and GIP-1 inhibitors, as well as SSRIs and SNRIs. And then we have our ACEs and our FACEs, which I like to refer to as the adverse childhood events and how they affect the development of our craniofacial complex. Basically, what that comes down to is how the neurology and trauma in the 0 to 3 population has an impact on swallow dysfunction, which then can translate into neurological and craniofacial developmental challenges. So, neural circuits, understanding the neurology, offers us options to create improvements in the neural circuits of sleep by embracing the benefits of neuroplasticity. Like I said, the ability to change our minds. And one of the leaders in sleep medicine came out and just said it. Not every dentist, physician, or the ones that teach others appreciate the connections between airway and the neurologic factors. AHI, apnea-hypopnea index, then is a failure. It just doesn't take enough of the evidence that's come out since 2000 into account. Dr. John Remmers. And I like to share some of this emerging science that has come out. There's so much, but this is what I find to be some of the most impactful. The Androsanis, Sleep Apnea Pathophysiology, released in 2023. It's a very in-depth look at everything, but to boil it down, they said despite its name, obstructive sleep apnea is not caused by an airway obstruction that prevents breathing. Based on their findings, they concluded that a dysfunctional mesencephalic trigeminal nucleus may be incapable of activating neurons in the ascending reticular activating system, and this will ultimately lead to sleep apnea. And I'm sure everyone's like, well, what do you mean? We didn't study this in our last sleep medicine course where they talked about putting an oral appliance in. And that's because this is emerging science. This is new data. This is really exciting. That the only time we actually quit breathing when we have an apneic patient is during the CAP-B phase of non-REM sleep. Fascinating, right? They dug into it. They found the answers. We should benefit from that. Before that article was released, that publication in 2023, we had an article that preceded it named Teeth in the Central Nervous System, What Happens When You Go to Sleep. And in this publication, they talked about the teeth and sleep and the relationship between them and how teeth are an important structure not only for chewing and the smile, but also for a better functioning central nervous system. And then the locus coeruleus literature review is pretty impactful as well. Basically, they found out that asymmetries in the trigeminal system as well as vestibular system and signals induced by malocclusion are detrimental for performance, and their elimination by occlusal correction improved cognitive performance in patients affected by Alzheimer's disease as well as in normal subjects. So Imagine this. They have a patient that's partially edentulous unilaterally and suffering from the symptoms of Alzheimer's. They create a partial denture. They recreate occlusal balance, and the symptoms of Alzheimer's and neurodegeneration improve. But they also did this correctly because they applied their therapeutic intervention to normal subjects, which also improved their cognitive performance, which is why you see athletes wearing, quote, aligners during play. It's because they are fixing their imbalances in their trigeminal system, as well as sourcing dopamine. But imagine if you had a table wobble. You sit down in a restaurant and one table leg is short. Someone's going to find a napkin or something to shove under there to fix it because it's very dissettling to have an imbalance. And that's what the locus coeruleus research did. It said, listen, if we have an imbalance in the trigeminal system, the whole body is going to go into compensation mode to try to fix it. Shoulders go up, hips go down, feet pronate, necks get crooked. The whole thing happens. And the locus coeruleus article is very, very fascinating to show our role as dentists and what we can do to either correct or cause a global dysfunction. In the first 1,000 days of life are when it all starts, for the good or for the bad. And this is a picture of my new grandbaby, and I am going to do everything I can to make sure that the trauma that she had during her delivery with a cord wrap and the things that might happen just as her little life develops, that those adverse childhood events don't have a lifelong effect. Because what happens, regretfully, and as the research is showing through the work of Norman Deutsch with neuroplasticity, as well as with Dr. Gabor Mate, who I'm going to introduce you to in a little bit, adverse childhood events create an early release of glucocorticoid exposure, perpetuating a supersensitization of those glucocorticoid release pathways, leading to memory loss and depression. So basically, if you learn to be stressed out when you're this age, as my little Gwen, you get really good at being stressed out, and people actually get addicted to their own stress hormones. And glucocorticoids kill cells in the hippocampus, preventing the creation of neuronal connections of long-term memories. And this creates a predisposition to stress-related illnesses for the remainder of their lives, including addiction, including cancer, MS, ALS, and I can only imagine how much it's impacting what we look at every day, which is sleep apnea. And then we have a gut-brain axis. And what we're figuring out is that they've done research and they basically said, hey, there's a certain population that can manage their anxiety and they sleep well, and another one that doesn't. And they looked at the bacteria that are in their gut biome, transplanted the bacteria they found for the calm people into the not calm people, and saw an improvement in their symptomatic presentation. So the relationships between the gut microbiota and the entire way we perceive sleep disturbances and sleep disorders, as well as the comorbidity with neuropsychiatric disorders, is a fascinating aspect of what we're talking about. Stasha Gomenak's been talking about this for a long time. David Gazal came out with his article a couple years ago, and this is a really interesting avenue for us to explore. And then we have our peptides or medications that are coming out. The norepinephrine reuptake inhibitor reboxetine alone, without a sleep appliance, without a CPAP, without a maxillomandibular advancement surgery, reduces obstructive sleep apnea severity. Riddle me that, Batman. It's a pill. There's another research to show the same thing, because it's a neurotransmitter problem, primarily. And that's what the research is coming down to. And then we have tirzepatide, significantly reduces sleep disruptions, and that's before the weight loss occurs. It's not just after the weight loss, it's happening before that, because it's getting into the dopamine pathways, we believe, because there's a lot of additional indications for tirzepatide that they're going to be coming forward as more and more people become familiar with their use. And this is right off the press. This is like less than a year old. And then we have the ability to improve form and function through light-based and laser therapies. And we've been using these for a while. The most familiar one, at least to me and most people that I talk to, is night lace. It's been around for a while. When it first started, it was one wavelength. It was the erbium YAG, which created heat shock proteins, and it would shrink up the palate. And then the other laser companies were like, well, I wonder if we can do that too. So now they're doing that with the CO2, but it is a much different application. So then night lace evolved and they started using the Nd:YAG with it, and night lace C3 was born. So when you have a patient or a provider that is familiar with night lace, sometimes it works and sometimes it doesn't. But what is the patient phenotype? So the Restore Lays protocol was developed by Dr. Derek Nordstrom, and it's a combination of Orlays Plus, which is the erbium. So we're using 1064 from traditional Orlays therapies and adding erbium to it, and then adding oral appliances on top of it to neuromodulate, because we can neuromodulate from a couple of different pathways. We can do mechanotransduction, which is what we've been doing with our mechanical devices and touch-based therapies. But when you put the light-based therapies on top of it, then you can use the best of both worlds, and that's what Restore Lays is. And then we have Soleil Sleep, and they are also doing a procedure with a light scalpel laser that I'm familiar or unfamiliar if they've actually named it yet, but I know it's in development. So as we were discussing the neuromodulation through the laser-based therapies, the 1064 is unique in its depth of penetration. So CO2 can't do it, the 980s can't do it, only 1064. And what the 1064 is able to do is get that depth of penetration to the microvascular layer to achieve the goals of neuromodulation by activating the mitochondria in the neuron. And that's another huge avenue out there that I'm just going to touch on Jack Kruse's work, as he's talking about light based therapies for dealing with the gut biome, and just how the mitochondrial dysfunction is at the key of a lot of our patients' core problems. But when we're activating the mitochondria through the power of light at the level of that microvasculature with the depth of penetration, we can get to those touch fibers, those proprioceptive fibers, and then we get immediately increased ranges of motion in areas like the tongue and the neck, and we're getting the hyaluronic acid that was a restriction moving, and therefore reducing pain, which means we sleep better when we feel better. That increased range of motion and the liquefaction of the hyaluronic acid as a neuromodulator helps people feel better physically and emotionally. And the first night's sleep after Orlays, people always are like, wow, that's crazy. I dreamed for the first time. And we're not increasing the size of the airway. We're not shrinking the collagen in the palate that quickly. We're strictly neuromodulating. This paper that was published in 2014 was titled Healthy Humans with a Narrow Upper Airway Maintain Patency During Quiet Breathing by Dilating the Airway During Inspiration. So basically their key points is that the muscles of the upper airway with healthy humans contract to dilate the airway. But older and more overweight subjects have smaller airways, and this is linked to increased active airway dilatation. But the data that they found showed that healthy subjects with narrow airways can overcome their anatomical risk factors for airway collapse by actively dilating their airways during inspiration. However, patients with obstructive sleep apnea, also with narrowed airways, show either little or no dilatory motion during inspiration, abnormal, or bidirectional movement, which means two phenotypes, both with small airways. One can breathe during sleep, but one cannot. And that shows that sleep is a direct reflection of the functionality of the neural circuits, especially those of the mesencephalic trigeminal nucleus, as the Andersonies are showing us through their amazing work. And this is what they said. Thus, we hypothesize that obstructive sleep apnea may also be the result of ascending reticular activating system neurotransmitter deficiency. Yes, it can have a comorbidity of a collapse, of a choke point, but the real underlying etiology is neurotransmitter depletion. And this is a good cartoon to be able to look at that concept in a picture form. That bird might not have bent that fence, but it sure looks like it did. So it sure looks like our patients who have a small airway in the CBCT are going to be our patients with sleep apnea, but that doesn't always translate. And that's, I mean, years ago at one of our AACP symposiums in Toronto, that was the point that was made, is that you cannot look at a static image with a CBCT to measure the effects of a dynamic airway. And I think that needs to be more out there. And what if the dental community could support the process of developing more efficient neural circuits to reduce the severity of those ascending reticular activating system neurotransmitter deficiencies? I think we can. We just got to know what we're working with. So, but how do we do that? The research that shows us and points us in the direction of how it can be done is very well described in this article, where yes, they're doing electrical stimulation, but we know that we can stimulate cranial nerves with other forms, including touch and including light. And in this paper, they quoted, therefore, cranial nerves are special targets for neuromodulation accessible near the surface of the body and direct afferents to the cerebrum, conceptually axons of the brain extending to the skin. And the leveraging of these unique features of cranial nerve stimulation to target a constellation of brain regions and functions and symptoms is in line with modern neuroscience. So look at the dental community. Neuroscientists, pretty cool, right? We just got to know what we're working with. So let's talk about 3 comprehensive care considerations. And there's more than that, but for the sake of this webinar, we're going to be going over these. We have our structural influences. We know that. We're good at that. We get it. And traditional therapies have focused on the size and the structural support of the airway. So we have all of these appliances and all of these devices that are efforting to do that. But do they always work to reach maximum medical improvement? If they did, we would have figured it out by now, and we'd all have happy patients all day long and never have to continue to look for answers. And then we have to consider the risks of treatment. So when a patient comes into your office and they've gone through a $30,000 MMA and they've done all the things and they feel better for a while, but they never, ever truly feel great. And they say, Doc, what can you do about it now? I trusted you and I really don't feel all that great. And now I have these other things. My face is numb or my disc is displaced. I can't touch my back teeth anymore. We have to know all of this. We have to not have a blind spot going in. But how could the results of treatment be more effective? By understanding the neural circuits of sleep. And this is the same article. And this emerging science creates the innovative opportunities to change our minds about the value of neuroplasticity. So the article states that given that afferent cranial nerve axons project directly to the brain, targeting structures like the thalamus and the cortex that are critical nodes in higher order brain networks, potent effects on cognition are plausible. So the proposal is an intervention design framework based on driving cranial nerve pathways and targeted brain circuits, which are in turn linked to specific higher cognitive processes, including breathing. And then the third concept is fascia and the low tongue posture and the vagal influences that can be all wrapped up in this big old mess. So what happens when the tongue doesn't do what the tongue is supposed to do, especially early in life, because even though all of these concepts are connected, sometimes the tongue is not connected to the brain neurologically as it should be. When I was in dental school, I didn't mind doing, class 2 preps on a plastic tooth when I can hold it in my hand. And, doing an adenoform was fine. But man, when that tongue got in there, I was like, what is this thing? This is my enemy. But really, I want everyone to think about it as their frenemy. Yes, in restorative dentistry, it's not necessarily your friend. And yes, and sleep medicine, it's not your friend. It's always falling back in the airway and screwing things up for us. But the frenemy is an oxymoron. And it refers to something that, despite a fundamental dislike, is also something that can be helpful. So we have 5 cranial nerves at the tongue functioning at midline 24 hours a day, 7 days a week, like almost 2,000 times a day. That's really, really, really big influence on the brain. What Nikki Mills did And she's a pediatric surgeon. She's an ENT in New Zealand, and she was confused. She was looking at her patients' outcomes from tongue tie release surgeries as she's trying to figure out this whole tongue thing. And some of them are getting better and were great, and others were not doing so well. And others, they went through the whole procedure, didn't really have a change. And she decided she had the ability to discontinue clinical practice and go into research and spend the time that most of us can't do in clinical practice and doing research. And what she found with postmortem dissections is that the lingual frenulum is not composed of connective tissue fibers that have an anterior-posterior orientation, nor is it a discrete chord band as described in the literature, but it is a fascial fiber that forms a frenulum that has a basket weave orientation as they cross the midline. Furthermore, the diagnosis and classification of the posterior tongue tie, which is based on a construct of a midline submucosal band, is not supported by her dissections. So as we learn more about this tongue, and as people look for answers to questions that they have, we have the ability to learn from them. What this drawing represents is the results of her publication, which the red line is mucosa, what you can see. The green line is fascia, what you can't see. And then that is a Genian glass that's underneath it. And her research showed that visual identification of the contents of the submucosal fold are impossible. That we don't know if the muscle fiber is being pulled up, if there's fascia in it, or if it is just mucosa for the most part. And that podcast that I have on the screen is really, really a good one for anyone who is dipping their toe or is already in the deep end of the pool in the tongue tie release world. So the Steckos did amazing work with understanding the role of hyaluronic acid, which in the drawing to the left is the blue lines that are interspersed between the superficial muscle fibers in the paramecium, but also in between the deep fascia and the muscle itself. So that hyaluronic acid is supposed to be a gliding lubricant that is moving, but with tissue restriction or injury, it doesn't move anymore. It's more of a glue than a goo. It's just stuck. And then you take that blue line, translate it into Dr. Mill's green line, which is that green line of fascia that's going up in there that is pulling the muscle up into that submucosal fold. And then this research was done, and it basically said that if the epimysium is disrupted during a procedure, so in other words, if the muscle is affected, the interface of that gliding hyaluronic acid, that lubricant that allows movement, is obliterated, it's gone, and we can't get it back. So that is a big thing for our patients who have had tongue tie release surgeries, and we're asking the tongue to do all the things we want the tongue to do. Being aware of our opportunities and our limitations based on the research is important because there's risks and rewards, there's actions and consequences. And what we all want for our patients is for a long-lasting marriage. We want the results of our treatment to last a long time and not be just a honeymoon and it go back to the way it was before. We want lasting results, and we need to look at the whole picture if we're going to be doing that. So this publication talks about the effects of tongue position on mandibular muscle activity and heart rate function. And this is one of the most difficult things for most of us to understand because we have a lot of patients who are doing exercises based on what they see on Twitter or YouTube and pushing their tongue to the roof of the mouth and holding it there for a long time. And maybe not feeling so much better, but thinking they're doing it. To be a successful human being, you have to be able to push your tongue to the roof of your mouth and hold it there, which is there's nothing physiologic about a human being that we do that on a daily basis. So they did the research. They had a study design where they had an experimental protocol of 3 periods. Baseline, where the tongue wanted to be, tongue placement on the floor of the mouth, and tongue placement on the roof of the mouth or the palate. The results indicated more activity in the temporalis and suprahyoid muscle regions, as well as a significant reduction in heart rate variability when the tongue was positioned on the roof of the mouth compared to the floor of the mouth. In other words, what we think that we're doing by telling people to force their tongue to the roof of the mouth and hold it there is not helping them. In fact, it promotes reduced physiological functioning, which is it does not allow relaxation, but promotes stress and increases in overall muscle activity as indexed by muscle tone and cardiac function. So what if some patients find a sense of calm through maintaining low tongue posture? What if they're upregulating their vagal tone so they can rest and digest, which is kind of important to sleep? And what if by repeatedly forcing the tongue from the comfortable low tongue posture that they've had to learn to do to survive through habituated oral exercises, they're forcing themselves out of their comfort zone and into having physiological stress? And what if, through the use of the floor of the mouth musculature, if someone cannot elevate their tongue the way it's supposed to through superior insertion with the soft palate that we all are worried about with our patients with snoring and sleep apnea because they're not using those muscles effectively, kind of like, floppy, underarms with the, women who wave and everything waves with the hand that's under the arm too. What if we don't have tone in there anymore because the brain and the soft palate quit talking a long time ago? And therefore, they can't use those muscles to elevate the tongue and the palate. And instead, they're using the floor of their mouth to push it up. And then they're creating pain. And they're having hyaluronic acid restrictions now under their tongue because they have a compensation. Kind of like lifting with your back instead of lifting heavy boxes with your legs. You can do it, but you're going to hurt something along the way. There's a consequence for that action. So, in this research, they basically summarized that tongue positions influence both motor and cardiac vagal activity in important ways. And now we have the opportunity for far-reaching implications of tongue position on self-regulatory functioning. And basically, this is a big one. Clinicians have an opportunity to teach patients a rest position of the tongue that truly fosters physiological rest. It's hoped that the field of oral facial pain, which is us, uses this information in the service of patient care that is based on the results of scientific study. It suggests there's an integration between tongue activity and heart function, which is also important for sleep apnea, correct? The results of the study replicated and extended the results of two previous studies. So no, I know a lot of people like, oh, it's just one study, the research, whatever. Everyone can prove something right or wrong with one research study. No, it validated two previous studies that demonstrated the same thing. And they show that tongue position has a significant effect on heart rate variability when the tongue was elevated to the roof of the mouth. So let's think about it. If we have the tongue elevated to the roof of the mouth, when there's a reduction in cardiac vagal tone, and if we extrapolate that information over when the tongue is lowered to the floor of the mouth, there can be a significant increase in cardiac vagal tone, resulting in relaxation. But that totally gets in the way of all of our sleep devices and all of the things, but it does make sense. It's a blind spot that we've had for a while. He doesn't have a blind spot, Patrick Mahomes. They basically, Science magazine posted earlier the year that tongue protrusions may improve the accuracy of Mahomes' hand movements. And anecdotally, amphibians stick their tongue towards prey. Basketball players stick their tongue out. Mice also jab out their tongues. Researchers wonder if humans' dexterity is likewise linked to their squishy mouth muscles. And they quoted, I think it is the center of our being, as crazy as that might seem. It's the center of our being in both pain and sleep. And we've all had our guessing machines challenged when we thought that we did the right thing, yet experienced the wrong outcome. So Dr. Nikki Mills had it. She's like, I got to figure this out. Dr. Derek Nordstrom actually developed the mandibular advancement device over 40 years ago and knew way back then that it was not the cure for sleep apnea. It's a Band-Aid. It's not the cure. And Dr. Gabor Mate realized that his symptoms of adult ADD and addiction, as well as those of many of his patients, were actually caused by early childhood trauma. And then the Androsanis discovered that the pathophysiology of sleep apnea is strongly influenced by neurotransmitter depletion and not exclusively as a structural collapse of the airway, or what we refer to in the industry as a choke point. Progress is impossible without change, and those who cannot change their minds cannot change anything. George Bernard Shaw. And what we like to do with the ABCDSM is move forward with a comprehensive perspective of wellness. We're honoring the legacy of leadership in the dental sleep community that we've had for many years now. We're evolving to meet the needs of our member providers as well as those who hope to join us. We're elevating opportunities for patient care, and we're embracing the future of sleep medicine by understanding the influences of the past. And this is our amazing board of directors that have been so busy over the last year. Dr. Kim Letterman, Dr. Terry Billings, Dr. Bazad Fareed, Dr. Stacy Cole, Dr. Ryan Robinson, and myself. and Dr. Jeff McCarty, and that's our board. We have several members who are also co-serving on the AACP board of directors. That would be Kim, Terry, and Robin, and myself. And Stacy just termed out as a director, and as did Jeff, and he's serving on the American Board of Craniofacial Pain. And Dr. Fareed has amazingly contributed to our amount of information that we're going to be putting into the new credentialing exam. And Dr. Letterman is immediate past president and the wind beneath my wing. So I thank her so much. So what's new with the ABCDSM? We're going to be developing a new logo coming soon, a new website. Corporate registration is completely new, and we have new bylaws. We're establishing a virtual examination proctoring process to allow providers to conveniently test from home or work while protecting the integrity of the examination process. We have an updated credentialing examination to reflect the relevance of the emerging science and the importance of pediatric airway. Our credentialing exam preparatory course is being developed so people who want to take the exam have something to study from. And our first hybrid course, it's live virtual meeting, is a collaborative effort with the Synergy Academy, is coming soon. We also are welcoming providers that realize that there are many aspects of sleep physiology that deserve visibility in our educational offerings. We're encouraging exploration of treatment modalities that can complement those that the provider already successfully utilizes in their practice. You don't need to change anything, but you might be able to add to it. We're going to have on-demand virtual learning management system exclusive to the ABCDSM provider community. We're applying for AGD PACE approval to award CE credits. That's in process. And we're also developing resources for subject matter experts to have a place to share their message with the ABCDSM provider community through our learning management system. Our event that we're having in November, as we're talking about neuroplasticity and neuromodulation, is called Changing Minds One Smile at a Time, exploring the aspects of the mental-dental connection. We're going to be discussing how craniofacial dental sleep medicine and the importance of the trigeminal neural circuits can change our lives and our practices, pediatric dental sleep medicine and the non-anatomical aspects of sleep, the functional neurological aspects of the swallow on the craniofacial complex, and the impact of adverse childhood events on the lifespan of health and wellness, both during sleep and wakefulness, and the influence of the gut-brain axis on sleep and anxiety, and the impact of sleep disruptions on mental resiliency. Our keynote speaker is Dr. Gabor Mate, and he is an internationally renowned author that is going to be with us to discuss the role of early childhood trauma and its relevance on physical and emotional development, as explained in his New York Times best-selling book, When the Body Says No. This information is groundbreaking, and it might shed some insight on our sleep community and why current therapies might be addressing only a portion of the underlying problems affecting our patients' lives, as well as our treatment outcomes. We also have Lieutenant Colonel Dave Grossman, who's a retired West Point psychology professor and Army Ranger. He's written extensively on the importance of sleep for both military personnel and civilians, and he talks about how sleep deprivation can negatively impact ethical decision-making, mental health, and overall well-being. And his work highlights the link between inadequate sleep and various mental issues, including depression, anxiety, and PTSD. So our guys are going to be talking about the beginning of life and how it starts and how it's expressing itself in our patients that walk in our office every single day. I'm going to be talking about connecting the dots between traditional aspects of dental sleep medicine and the emerging science as related to the role of neural circuits, how we can identify patients who do have the neurological primary deficit and how to overcome it through neuroplasticity and the application of different tools and tricks. Dr. Stacy Becker is a diplomate in the AADSM, as well as a fellow with the International Congress of Oral Otologists, and she's a founding member of the ASAP pathway for pediatric airway and a passionate advocate for addressing the lifelong consequences of sleep-disordered breathing. Christy Gatto, who's a speech and language pathologist, she's also an author and a leader and instructor in the field of oral facial myofunctional therapy. And her presentation will be exploring the functional and neurological aspects of the swallow as a neuroreflexive system that is influenced by much more than just a series of exercises based on repetition and compliance. And then Stacy, Christy, and I, for those who are interested in the hands-on component of what appliances to use, what therapies to do, what assessments to do, We're bringing a diverse perspective of the craniofacial dental sleep community in the 3I course, which is identifying invisible influencers, because we got to keep it real. We got to bring this into our office on Monday and make it work. So I'm doing craniofacial dental sleep medicine. Stacy's doing pediatric. And she's also bringing in all of the information she's had from her podcast series for all the big innovative experts from around the world. And then Christy is going to be talking about the functional and neurological aspects of the swallow on the craniofacial complex, which, as you've heard through this presentation, is huge. We're going to have hands-on learning to immediately assess and identify opportunities to improve treatment outcomes. We're going to implement therapeutic techniques to demonstrate the provider to treat or refer for the invisible influencers of health and dysfunction. And we're going to have real-world implementation, including forms and documentation and treatment sequencing to bring back into the office. So the 3 I's are identifying the invisible influencers with immediate implementation of ideas. Through the Changing Minds meeting and our educational outreach that we're developing for our community, we're hoping to support them and get a great organization going forward. Our Changing Minds meeting is going to be talking about neuromodulation and neuroplasticity, but also hoping to change some minds about the possibilities of dental sleep medicine. We're going to continue our legacy. We're standing on the shoulders of our founders while looking confidently into our future of the American Board of Craniofacial Dental Sleep Medicine. For more details, visit abcdsm.org. And the only way to make sense out of the change is to plunge into it, move with it, and join the dance. Alan Watts. And that's what we're doing. So thank you for listening. It is now time for Shaylin to open it up for questions and answers.
Thank you so much, Dr. Tenholder, and thank you for all of the great information as well as the exciting upcoming news for the ABCDSM. We do have a couple of questions. The first one is, where is the proper rest position of the tongue and its 8 pairs of muscles?
That is a really complex question, and I don't know that I would even be able to start to do it justice with this particular presentation, but that is something that Christy's going to be talking about in the course and in the conference. So the course the day before, we getting into the actual hands-on identification of that, and that rest posture might be different for different people based on their phenotype. But basically, we don't want the tongue suction to the roof of the mouth. That is not a physiological advantageous position. But I don't want to get in the weeds of it. It is very complex, but as you heard from the research that we presented, it could be different for every patient based on their phenotype.
And when do you anticipate the practice session for the ABCDSM diplomate will be available?
We're hoping within about 3 to 4 months. We just, literally last week had our board of directors vote on all of these things. So this is literally fresh off the press. It's literally less than a week old, just like my grandbaby. So we now have the green light. We've set up our LMS. We're building out the resources. We have the test pretty much ready to go, and we just now got to get it in place. So our goal is the end of the year, and we're hoping to get it done before then.
Wonderful. Thank you very much again. We have comments in the chat as well, thanking you for the great information for the future of the ABCDSM and for introducing these concepts.
You're very welcome. This is my passion and my pleasure, and I'm happy to share it.
Thank you, Dr. Tenholder. Have a great evening, everyone.
Bye. Thank you.